right. So I do have a couple disclosures, none that are truly pertinent to this talk. So the last 12, 15 years really represents a therapeutic evolution when it comes to aortic valve therapy and transcatheter valve therapy at that. The questions really are how we got there and where we go from there. So we start with aortic stenosis. On the left, we see a normal trileaflet valve, and on the right, we see what represents what we call degenerative calcific aortic stenosis. So sparing of the commissures as opposed to rheumatic disease with nodular thickening of the leaflets and then restricted leaflet opening. The guidelines have evolved that we kind of characterize that now as class C1 is our asymptomatic severe AS patients. So this is just defined as a maximum velocity across the valve of 4 meters per second, mean gradient greater than 40, or a valve area less than 1 centimeter squared. Those are your asymptomatic patients. Your symptomatic patients generally are those with severe AS who have developed the cardinal symptoms of aortic stenosis, generally speaking, chest pain, syncope, or heart failure. Fatigue in the elderly is certainly a common symptom that will occur. And we know what to do with these patients. So we do know that symptoms and the onset of symptoms or left ventricular dysfunction portends a poor prognosis. And we also know that fixing the valve is associated with a reduction in mortality and actually a return to what is considered to be a generally normal life expectancy. Of course, there's a mild upfront risk of therapy, but a normal life expectancy once the valve is fixed. Aortic valve replacement across the board is this surgical aortic valve replacement is the standard. And looking at the STS from 2002 to 2010, this is a recently published paper in Annals of Thoracic Surgery. 30-day mortality across all patient populations is about 3%, with a stroke rate of about 1.5%. That's the bar, and that's the standard that we're trying to reach. In the elderly patient population, this is a paper that's often quoted. Surgery is often denied. Now, we don't necessarily think of it that way, but there's a bottleneck somewhere where either it's at the level of the primary care physician not referring the patient, at the level of the cardiologist on the initial evaluation not thinking they're a surgical candidate, and rarely at the level of the surgeon, because usually these patients are filtered by the time they even get to the surgeon. But a number of patients are denied surgery, and when you look at why that is, it's often advanced age, LV dysfunction, CHF, or multiple comorbid conditions. So how do we define risk? There's the objective risk assessment, of course, and there's a subjective risk assessment. When we look at objective, this is out of the STS. This is a database that's populated basically by the centers performing surgery and reporting to the STS. And this is the risk calculation that comes with that. It's somewhat dynamic, where certain variables may or may not have as much weight as we go through the years. But you can ultimately come up with, on the right, a risk of mortality, morbidity, mortality, long length of stay, et cetera, et cetera. But this is about 24 variables. It doesn't capture everything. In particular, it doesn't necessarily capture liver disease, porcelain aorta, radiation, oxygen dependence, or most importantly, especially when we get into the elderly population, frailty, which is another very important issue that speaks to the patient's reserve, the ability to get through not just the operation itself, but the postoperative course that they will entail. For patients who are not candidates for surgery, up until about 2002, 2004, this is all we had, balloon valvuloplasty. It's kind of a fun procedure. It does relieve some of the pressure on the heart going through that valve with a 30 to 50% reduction in the gradient and an increase of valve area of about 0.3 or 0.4 centimeters squared. The only problem is it doesn't work. It doesn't last. The mortality at 2 years is the same as an untreated population. So this procedure was something that was good for bridging or temporizing purposes, but never really a long-term outcome could be expected from it. So in 1989, the concept was first developed, and this is the original prototype of the valves that we're using today. This is the Anderson valve, and the first animal implant was in a pig in 1989. In 2002, Alain Cribier and his colleagues in Rouen, France, found a 57-year-old gentleman with severe aortic stenosis and about every other comorbidity possible. He was not a surgical candidate, and they attempted by an antegrade approach. So this was done via transeptal access into the left atrium, left ventricle, and then across an equine valve, which is the first prototype of the Cribier valve, and they were successful. The patient lived for 17 weeks and then died of every other complication that was relevant to him not being a surgical candidate in the first place. But it did show the possibility of doing this and doing it reasonably well from a transcatheter approach. That ushered in the era of the studies. So this is partner B, looking at extreme risk inoperable patients, and what we saw at 1 year is a 20% absolute reduction in mortality. CoreValve showed the same thing, and this is the self-expanding valve by Medtronic, which set a performance goal of 43%, which was the lower limit of what's expected with the Edwards valve, and they also showed superiority compared to what was perceived to be medical therapy. In patients with elevated surgical risk, we've seen the same thing. So this is now surgical aortic valve replacement versus transcatheter valve. This is partner cohort A. At 1 year, we have similar mortality, all-cause mortality at 1 year. And the same thing, a similar trend is shown with the US CoreValve study. So these were the pivotal trials that led to approval of TAVR, first in inoperable patients and then in patients at elevated surgical risk. So we go from here in 2002, and what my favorite part about this picture is they're all drinking champagne in the hospital. So that's the beauty of France, I'd like to say. But this was the first patient. This was obviously between the time of the procedure and 17 weeks thereafter. But we do have now guidelines. To go from 0 to guidelines in 12 years is something remarkable. And what we see here is a surgical aortic valve replacement is certainly recommended in those that meet the indication for AVR with lower intermediate risk. And then TAVR now carries a Class 1 guideline recommendation for those at elevated or prohibitive risk, provided they have a 12-month life expectancy. And that's what we're going to end up talking about a lot as we go. From 2012, when it was first really approved, all the way to Q3 2014, we've seen a huge uptake in the number of centers that are performing TAVR and enrolling patients in TBT Registry, from 11 centers in 2012 all the way up to about 330, and that number is continuing to rise. Just in our area, North and South Carolina, there's now 17 sites that are actively implanting transcatheter valves. So our current challenges really are defining the optimal population. What's the risk profile we should be looking at? How do we understand what futility truly is? And how do we optimize short and long-term outcomes? We do that clearly by minimizing complications. Stroke, vascular, and paravalvular leak are the ones I'll talk about today. And then optimizing cost. This is expensive therapy. These patients don't live a very long time afterwards, and we have to get better at this. So looking at indications evolving over a period, we have low to moderate risk, which are clearly aortic valve replacement, surgical aortic valve replacement patients. We have high and very high risk, where the bar is moved towards TAVR, and then we have the truly inoperable patients, where it makes you wonder what we should be doing. What we've learned pretty quickly is that there is a cohort of patients in inoperable that shouldn't be touched at all. These are the quote-unquote cohort C patients that when we first brought this out, Washington Hospital Center in 2007, when I was a fellow there, we didn't really care beyond the excitement of a technology. I think everyone in this room recognizes that when a new technology comes, when you have a chance to treat people who were previously untreatable, it's exciting. You sometimes maybe subconsciously even lose track of what their ultimate outcome will be just by virtue of the fact that you might be able to treat their acute problem. We could treat the valve, we didn't really treat the patient. Those patients are cohort C, we should not be treating them. And as we move into lower risk, we have clinical trials going on right now. The partner to the S3I program looking at intermediate risk with the balloon expandable stent, and then SIRTAVI, which is looking at intermediate risk core valve patients, self-expanding patients. And there are other trials in Europe and in the US that are currently ongoing or close to beginning. Looking at cohort B of partner, looking at the inoperable cohort, we did have a 20% reduction in mortality compared to medical therapy alone, but we still had a 30% one-year mortality in the treated patients. That's good, that is better than nothing, but it's not good that it's that high. And if we look at 5 years, while we still have a delta of 21.8%, a number needed to treat in order to save a life of 4.6, we have 71% of patients dead at 5 years. So this is a tough population now. Is it just the fact that we had to start at extreme risk, or is it the fact that these patients maybe shouldn't be treated long term? This is an actuarial nightmare, as you can imagine, when it comes to life expectancy and what comes with that. When we look at outcomes, though, we can stratify based on the predicted risk of mortality. So STS patients less than 5 who are considered inoperable, this is usually technical reasons for which they are not operable. This isn't the variables that are typically placed into the STS. Those patients clearly do better with TAVR than with medical therapy, but as we move to higher clinical risk strata, when we move to patients with significant renal disease, or prior bypass surgery, severe heart failure symptoms, emergent procedures, unrevascularized left main disease, for instance. All of these things bump up the STS predicted risk. And as the risk gets higher and higher, we start to lose that therapeutic benefit even compared to medical therapy. This is something that we do need to think about. In US core valve, when we look at some of the comorbidities that lead to patients being inoperable, the predictors of a poor outcome could be considered frailty, so wheelchair bound or an albumin less than 3.3. That speaks to functional reserve. That's highly significant. Home oxygen, STS score, prior CABG, these are comorbid conditions, and what you see are trends or small p-values towards significance in predicting bad outcomes. And then the mean aortic valve gradient, this speaks to the physiology of a patient with something such as low gradient, low flow, low EF aortic stenosis. When we move towards intermediate risk, what we have to think about here are that surgery is getting better and better and better. And when we go from 1999 to 2011, this is Medicare data, we see that at all strata of age greater than 65, 75 to 85, and then 85 and up, what we see is that mortality is going down. So this may be a reflection of the fact that we're learning. This may be a reflection of the fact that transcatheter valve therapy is taking the highest risk patients out of this, but it's also very much a reflection of the fact that surgery is getting better, and I think we all have to realize that. We look at a couple different papers at high risk on the right. This is predicted and observed mortalities. Patients at high risk seems to be pretty accurate, but intermediate risk predicted by the STS, surgeons are typically outperforming this, and that's something we need to consider when we look at the intermediate risk patient and start to prescribe them therapy, either transcatheter or surgical. When we look at complications, we have a fair amount, there's no doubt about that. Bleeding complications are rampant, 22% for major bleeding, and all bleeding is up at 41% of all cases. Now, these numbers are coming down. The original devices, as you all may be aware, were 22 and 24 French. Now we're down, depending on the device, to 16, 18 French, and in some of the clinical trials, we even have 14 French devices. On the left, we have death, major and all. I submit to you that all death is major, so the blue is an in-hospital death, while the red is 30-day mortality. And then vascular neurologic complications outside of bleeding are significant. Cerebral emboli is common. This is probably what leads to a lot of our strokes. It's not necessarily the valve itself or the calcium on the valve. That tends to stay put, and we have series that go back a long ways with aortic valvuloplasty demonstrating that most of the strokes that occur, either one of two things. It's either stuff on the aorta that we're knocking off with the catheters and the wires, or it's a watershed effect from the hemodynamics that occurred during the TAVR implantation or in the immediate post-implantation period. But major stroke is important. What we see here in cohort B is a significant increase in mortality in patients who have stroke. And we're going to show the same thing in a moment with vascular complications. There are some cerebral embolic protection devices that are out there. These are approved in Europe and under study in the United States. There are a couple studies going on. We may be one of the centers with one of these coming up, and these are implanted in different ways, one of which is through the radial artery, where it's deployed in the ascending aorta. It covers essentially the innominate and the left carotid and can help reduce the incidence of micro and macro embolization. Vascular complications are another important thing. This was our second case. Very proud of this one, of course. But what you see on the left is a perforated common iliac artery, and what you see on the right is the common iliac artery on the dilator. Things that we certainly need to try and avoid. All right, so paravalvular leak is another major issue. This is probably our Achilles heel right now when we think about this. The stent valve itself cannot necessarily oppose completely an irregularly shaped annulus with a lot of calcium. As a result, we will have a little bit of leak around the valve. When we do, the severity of it does predict mortality, while moderate to severe paravalvular leak, in fact, any amount of paravalvular leak is associated with worse outcomes. Moderate to severe is certainly associated with much, much worse outcomes. Ways to avoid that is our evolution of annular sizing. While the initial studies were done with TTE or TEE guidance, we've now moved to CT almost uniformly in everyone, and we're not unique in this. Every center has pretty much grasped this concept. And what we do see with TTE versus CT, the CT is associated with significantly less paravalvular leak, and also, as a result, less death, rupture, and severity of the leak itself. So the next thing we have are device evolution. So these are 3 devices that are currently in trials now. On the left, we have SAPIEN 3. This is Edwards' balloon expandable device, which is now deployable through a 14 French system for the 23 and 26 millimeter valve and a 16 French system for the 29 millimeter valve. There is an adaptive skirt on the bottom, which is supposed to help reduce the severity of paravalvular leak. In the middle, we have the Lotus valve. This is Boston Sci's device, which is 18 French and currently in clinical trials. It's approved in Europe, but in clinical trials against CoreValve here in the United States. This has an adaptive seal. It has a couple other advantages, kind of capturing what we call the 3 R's now: repositionability, resheathable, and recapturable. So this device, if we don't like it, can be totally recaptured, even removed from the body and started up again. So this was also the one, incidentally, that was on Grey's Anatomy, if any of you watched that about 1.5 years ago. And then on the right, we have Direct Flow, which is another device that has the potential for an adaptive seal that will reduce the frequency and the incidence of significant paravalvular leak. So the last thing I want to focus on are reducing costs. Obviously, this is an issue. Improving cost effectiveness is the biggest thing. I'm always reminded that we have 5 pillars of excellence: service, people, growth, quality, and finance. But let's be honest, it's the last one that runs the whole show. So how do we do that? How do we save money? When we look at cost effectiveness of TAVR, there's really no question that based on our current standards, compared to dialysis, of course, it is a cost-effective therapy in terms of quality of life, quality adjusted life years saved. The problem is with these patients with severe aortic stenosis and multiple comorbid conditions, if you look at the list of all the therapies that are there, they've probably already had about 6 or 7 of these cost-effective therapies. How many can we afford to give? This is a real issue, and it's not just in TAVR, it's everywhere. So what we really need to do is at least just select the right patients. If you select patients that will benefit, you will, even for a fixed cost, you will improve the cost effectiveness. And if we look at the incremental cost of complications, this is really where we are. Death costs $42,000, major bleeding costs $32,000, renal failure costs $68,000, and a repeat TAVR costs $120,000. So we got to be pretty careful about that. But these complications portend increased costs, and these are things that we need to try and reduce in order to improve our cost effectiveness. Other things we can do is adopt a more minimalistic approach. Does every patient need a Swan, a Foley? Does every patient need perfusion pumps primed? Does every patient need every stop that we used to do? If you go back to the original CoreValve trials, the original patients in CoreValve were done with tandem hearts for support. Now we pace them at 120 and we're done the procedure in about 45 minutes. We've come a long way. We don't necessarily need the same stops that we used to have. And if we do that, if we do take a more tailored approach to this, we may be able to reduce costs. This was a series of 142 patients from Emory that showed that that can actually happen. So in conclusion, TAVR is mainstream therapy. There's no question about that. It's likely to have a further indication shift. We'll see some intermediate risk subgroups come out. Truly low risk will be very doubtful for a while. It's very hard to argue a 20-year outcome seen with surgical aortic valve replacement, nor should we even try to argue with that. There's a focus on safety, and there should be: vascular complications, PVL, and stroke. Focus on costs, device procedure, and the hospital. And device evolution will certainly be interesting. With that, thank you very much. It's great to be here.